Good day, ma'am. I am Rosann Naval, a fourth-year medical student of the Naval Medical School Foundation, and I am in charge of doing your baby's physical exam. Are you comfortable with English, ma'am, or do you prefer Bisaya?
English ra?
Okay, so may I ask the patient's name and age, please?
Elaine, 7 days.
I will check all the aspects of your baby, so this might take a while. Will that be okay with you, ma'am?
Okay.
Okay. These are the materials that I will use as we go along. Infantometer, infant scale, thermometer, lubricant, tape measure, pen light, stethoscope, tongue depressor, and BP apparatus. May I start?
Yes.
The first exam will be the general survey and the baby's vital signs. To check for her length, I will have to place a child in a supine position on an infantometer, or measuring board from head to heel with hips and knees extended. Your baby is 48 centimeters. To check for her weight, I will directly put her on an infant scale. Your baby is 3 kilograms. I will measure her head circumference by placing a measuring tape around the widest diameter of the head. And her head circumference is 35 centimeters. Now I will check the vital signs of your baby. It is not routine to measure the blood pressure in normal children, but I would just like to mention that the appropriate BP cuff must be used. Now I will palpate her radial artery to feel her pulse and count how many beats I feel in 1 minute. Her pulse rate is 140 beats per minute, which is normal for a baby her age. For her respiratory rate, I will just observe how many times she will breathe in a minute. It's good that she's asleep now because this will be the most reliable. And her respiratory rate is 50 cycles per minute, which is within the normal range. For her temperature, I will place the infant supine and insert this well-lubricated rectal thermometer, and we will wait for 2 minutes. Her temperature is 36.8 degrees Celsius, which is normal. Now, I will inspect the patient's skin. Her skin is pinkish. This whitish substance on her face, which we call milia, are just normal findings in a newborn, and this will eventually disappear. There is no jaundice, no acrocyanosis, no benign rashes, no birthmarks. I will now palpate the patient's skin to assess the skin turgor. How often does she breastfeed?
About every 2 hours.
Okay, her skin is soft and not dry, and there are no signs of dehydration. Now I will check your baby's head. Her hair is black, thick with good luster. There is no head swelling like caput succedaneum and cephal hematoma. Now I will palpate the head of your baby. I can feel the anterior and posterior fontanelles are soft, which is appropriate for her age. Now I will perform the Schwostek sign. I will percuss the cheek of the baby just below the zygomatic bone in front of the ear. There is no facial grimacing, which is normal. Next are the eyes. May I ask you to hold the baby upright facing me? She has anecteric sclerae. Pupils are black, and there are extraocular movements. Now I will use my pen light to see if there is pupillary reaction. And yes, the pupils are equal and reactive to light. Next are the ears. The ears are equal, not low set, and are in line with the outer canthus of the eyes. For the nose, I will test for the patency of the nasal passages. I will occlude each nostril gently while holding the mouth closed. Both nasal passages are patent because the baby was able to breathe with no problem. Nasal septum is midline. For the mouth, I will check with a flashlight and tongue depressor. There is no tooth eruption, no cysts, and gag reflex is normal on both sides. Next, I will assess the neck. The neck is supple and the trachea is midline. I will now palpate it to check for masses and lymph node swelling. There are no lymphadenopathies, and as I palpate the clavicles, there are no evidences of fracture. Next, I will check the thorax and lungs of the baby. I will observe her respiration and breathing patterns. She has normal color, breathes through the mouth, and is not in respiratory distress. Now I'll put my hand on your baby's chest to feel the symmetry of transmitted vibrations as she makes sounds. Her lungs are equal and symmetrical. Now, I will auscultate the baby, and I will start from the top going down. The baby has clear breath sounds, no wheezing, no crackles. Next is the heart. I will observe for cyanosis, irritability, and fatigue. Your baby is playful and there's no signs of cyanosis around her mouth. I will now try to palpate for the point of maximal impulse or PMI of the baby's heart. And it's normal in babies if I can't feel it. Using my palm, I will also feel for the thrills. The PMI is not palpable and there are no thrills. Using my stethoscope, I will now listen to the baby's heart. Both S1 and S2 are distinct and single, and there are no murmurs heard on all valves. Next, I will assess the breast of the baby. Her breasts are not enlarged. For the abdomen, I will inspect the baby while lying supine. Her abdomen is flat, umbilical cord has no redness or swelling, and there are no umbilical hernias. I will listen to the bowel sounds with the bell of my stethoscope. There are clicks and gurgles heard, about 10 per minute, and there is also occasional borborygmi. Now I will percuss and palpate her abdomen. The liver edge is 2 centimeters below the right costal margin. The spleen is more than 1 centimeter below the left costal margin. I will now inspect the genitalia. The clitoris is of normal size. Labia majora has normal size and color. There are no discharges, rashes, bruises, and any external lesions. With a gloved hand, I will separate the labia majora to inspect the urethral orifice and labia minora. They are both normal. The hymen is thickened, which is normal in newborns. There are no discharges or any other unusualities on the vaginal opening. I will no longer perform the rectal examination since the baby has already defecated. Do you have any other concerns regarding her rectum and anus?
No.
Now I will examine her musculoskeletal system and I will start with her hands. Her hands are clenched but can easily be opened. Then to her clavicle. There are no lumps, masses, tenderness, or crepitus. Then to her spine. There are no abnormal spots, hairy patches, or deep pits. Now I will examine her hips for signs of dislocation. I will be doing the Ortolani maneuver to check if there is posterior hip dislocation. I will place the baby supine and will flex her legs to form right angles at the hip and knees. And I will place my index fingers over the greater trochanter of each femur and my thumbs on the lesser trochanters. Then I will abduct both hips simultaneously until lateral aspects of each knee touches the examining table. Your baby doesn't have any posterior dislocations. Now, I will do the Barlow test to check for the ability to sublux or dislocate the intact but unstable hip. I will place my hands in the same position as before, and I will pull the leg forward and adduct with posterior force. I will press on the opposite direction with my thumbs moving down toward the table and outward. I'm trying to feel for any movement of the femur laterally, and in this case, there is none. Now I will assess the legs and feet for symmetry, bowing, torsion, and discrepancy of length. I will put the end of the measuring tape on her anterior superior iliac spine and to the medial malleolus. I will also do that on the other side. Both of her legs are of the same length. Now I will assess the baby's nervous system. The baby is alert and moves head toward the sound when awake. I can move all major joints through the range of motion. There is no spasticity nor flexidity. Her tone is normal. I will test for sensory function, and the patient withdraws the limbs as soon as I try to squeeze the extremities. Now I will try to test her cranial nerves. Cranial nerve 1 is very difficult to test in newborns. The infant can regard my face, and there is facial response and tracking. She also blinks in response to light. She can track my smiling face, and her eyes move together. She has rooting reflex, and she has a strong suck. When she smiles, there is symmetry of the face. She blinks both eyes in response to loud noise. Her swallowing is well coordinated, and there's presence of gag reflex. Her shoulders are symmetrical. There's coordination in her sucking, swallowing, and tongue thrusting. When I pinch her nostrils, she opens her mouth with tip of the tongue at midline. As I place my finger on her palm, She will flex her fingers and grasp my finger. As I touch her sole at the base of the toes, she can also curl her toes. For the rooting reflex, as I stroke the perioral skin at the corners of the mouth will open and the infant will turn the head toward the stimulated side and suck. For the Morrow reflex, I will hold the infant supine while supporting her head, back, and legs, and as I abruptly lower her entire body, her arms will abduct and extend, her hands will open, and legs will flex. And as for the asymmetric tonic neck reflex, I'll put the infant supine again, turn her head to one side, hold her jaw over her shoulder. Her arms and legs on the side to which the head is turned will extend, while the opposite arm and leg will flex. And it also happens on the other side. I'm finished with the examination of your baby, and everything is normal. Thank you for your patience, ma'am.